Hello, Level 4. This is the dossier promised about TPN. I'm going to separate TPN from CVADs so that if you feel comfortable with TPN, you can just watch the CVADs and vice versa. And if you want to watch both, you can. So this one is going to be exclusively on parenteral nutrition. Now, I know in the last workshop, we had mentioned some page numbers for the 11th edition, and I know that a lot of you have the 10th edition. Luckily, the ones that we were talking about ended up being the same page numbers, which is like finding a needle in a haystack. So we're not going to be mentioning any page numbers from now on per instructor request. We are going to be referring you to your index. If we mention a table or if we mention information, we will be sure to emphasize what that subject matter would be. You should have an idea of what your reading is, and it's always going to be within that reading, unless we say something like go over something outside of what the reading's recommended in order to reinforce the physiology. We'll be sure to let you know like what that content is, but the point is we want you to be able to find it on your own in the textbook, whether it's through the table of contents or the indices. And that comes from some classes having the 10th edition while others have the 8th. So I apologize for any inconvenience that might have caused you. So let's get started with parenteral nutrition. So from now on, I'm going to be abbreviating this as PN. This is, according to your book, the administration of nutrients directly into the bloodstream. So we are administering different nutritional molecules into the patient's bloodstream. And you might wonder, well, what is that and why would you want to do that, basically? And so let's talk about some indications when it comes to parenteral nutrition. So some indications include a compromised GI tract. A compromised GI tract includes disease states that may cause the loss of ability to ingest, digest, and absorb essential nutrients. I'll list some here. They are in a table in your book, which go ahead and make sure you find that chapter that parenteral nutrition is found in, whether it needs to be in your index or table of contents. It's probably in your index. So it may be something related to a bacterial infection that causes chronic, severe diarrhea and vomiting. It may have something to do with a complicated surgery where the bowel needs to remain sterile before it becomes functional. Because if that bowel is introduced to non-sterile food but has not healed yet, then that's going to cause an infection. Another cause or an indication for parenteral nutrition is complicated trauma. So when Miss B was talking about spinal cord injury and how these patients, pretty much every patient who's going to be in the ICU, who's being so sedated is going to be at risk for slow bowel tract. Think about the fact that the sympathetic nervous system shunts blood away from that tract, and so your body wouldn't be paying attention to that part of the body as much. And so there's that risk for paralytic ileus related to those neurologic problems. Complicated trauma could also include that involving the GI tract. And make sure you know when we need to start nutrition, whether it's enteral, meaning through the GI tract, or parenteral nutrition. It's usually going to be within the first 3 days of trauma. I just wanted to add that as a side note because it is mentioned in your textbook. A GI obstruction, which could also be a complication associated with paralytic ileus, where that bowel is just not moving things forward. And if it, especially in the colon, which is primarily responsible for water reabsorption, there becomes some sort of hard, compacted piece of stool. Nothing can get past it, so you would see that increase in abdominal girth. So while you're looking at these indications, I want you to think about what they look like on the floor, because in not only in the testing world, but in the nursing world especially, you're not going to walk into a room where no one really knows what's going on with the patient, and the patient's going to say, oh, I have a GI obstruction. So what you want to know is those clinical manifestations. So if you see any of these indications and you're like, well, I don't remember what that looks like, I don't really remember learning about that, make sure you take that independent initiative and go look for it in your book. There may also be GI tract anomalies or fistulas. There's an N supposed to be there. Anomaly meaning abnormality. Fistulas connect one organ to another, or maybe one part of the body to another that is not natural. So, for example, I once had a patient who had a fistula between her vaginal canal and her anal canal. So you can imagine where the feces would be coming from and how that would put her at increased risk for infection, and how you might not want to be adding non-sterile contents to the GI tract. Intractable diarrhea. So they're not really sure why the patient may be having diarrhea. Severe anorexia nervosa, where the patient, this is a psychological consideration, the patient may have body dysmorphia and may consider themselves to be of a weight that they don't find to be appealing. And so they refuse to eat to become thinner and thinner because that's what their desired body type would be. So if your patient is refusing to eat, then parenteral nutrition may have to be the only option. Severe malabsorption, like those diseases you learned about in level 3, Crohn's disease, ulcerative colitis, also short bowel syndrome. Now, in terms of parenteral nutrition, these are the indications for them. Now, what I want you to understand is it is essential for you to understand what is in parenteral nutrition. So I'm going to put this in red. So with the composition of parenteral nutrition, one thing to keep in mind is that is going to be reformulated as the patient's condition changes. So like Professor Burgess talked about, and we talked about it together, that it's not necessarily an organ system in isolation or a disease process in isolation. What if you have a patient who's experienced some sort of complicated trauma and a brain injury and has now developed SIADH and therefore dilutional hyponatremia? So that would require the TPN, which normally contains sodium because it's essential in our body, to be titrated based on what the patient's condition is and what the lab values are. So this, in particular, this reformulation is going to require that interprofessional collaboration, where you as a nurse are notifying the physician, you're notifying dietary, what's going on. Maybe not dietary, because I know for those of you in Baycare, you're probably like, I need to let the people who bring the trays know, because it doesn't seem like they'd be eating. That's not what I meant. Basically the physician and the mid-level practitioners. So in terms of commercially prepared parenteral nutrition, there is dextrose, which is essentially sugar. So that's glucose, that's sugar. And that's going to provide the bulk of the calories in TPN. There are also amino acids. And if you remember way back from A&P, way back from level 1, I'm sure they mentioned it in 2 and 3 as well. These are the building blocks of proteins. So with amino acids, you may be asking, well, why don't they just put the protein in there? When we eat as a healthy individual, what happens is we intake protein, and that goes down through our intestinal tract, through our stomach, and down into our small intestine, where it is broken down into smaller building blocks. Now, there's a blood system that leads to the portal circulation to the liver that delivers everything from the GI tract through the liver so that it can reassemble these amino acids into plasma proteins. So what we're essentially doing is bypassing not only the stomach, the small intestine, the large intestine, but we're also bypassing a lot of other things in order to provide the basic pieces necessary for the liver to synthesize those proteins. Moving back to electrolytes. So the electrolytes are the typical ones you hear about, right? Because those are the important ones. Sodium, potassium, chloride, calcium, magnesium, and then we've got phosphate. So what I would encourage you to do is go to the NIP Commons, and if you feel weak on fluid and electrolytes, go ahead and listen to those Understanding Electrolytes and then Fluid Balance and any other videos that you can find on the Nursing Commons as well, in order to help bolster that understanding. If you don't feel like rereading the book, which most students, you don't really want to read the book. It's understandable, but we do have ways of engaging you on multiple levels. So I would encourage you to go ahead and access those videos, which can be found in the NIP Commons. And the ones about electrolytes and fluid can be found under level 2, because that's where you got, your med-surg content. So those dosaries are available in the NIP Commons as well. Let's look at what is also found, not might be, but should be found in TPN, or parenteral nutrition. There are 2 different types of PN. It would be TPN and PPN, and it depends on the type of catheter that you're using, and we'll talk about that later. So the others that you may find are vitamins that are essential. So vitamin A, vitamin B. We want to know our fat-soluble vitamins are A deck of cards, right? So vitamins that are fat-soluble are A, D, E, and K. So vitamins are going to be found in parenteral nutrition as they're necessary for various functions within our body. And we've learned that through our studies in anemia and bone health, in particular vitamin D. So the big ones that I just want to mention that are fat soluble are vitamin A, D, E, and K. And because they're vitamin soluble, there is a possibility of overdose. However, a lot of vitamins, most other vitamins, are water soluble and will be excreted through the kidneys if they're found in excess quantities. So just keep that in mind, that these are the ones that are fat soluble. And it is possible to overdose on vitamin D. Some trace elements are also found. These include zinc, copper, selenium, chromium, and manganese. So trace elements is what you may see in parenteral nutrition. There may be a 3-in-1 or total nutrient admixture that's pre-prepared containing an IV fat emulsion. So you may have seen on this previous slide that we have dextrose and we have amino acids, we have electrolytes, we have trace minerals or trace elements, we have vitamins. Now you may be asking yourself, well, what about the fats? Because we do need fat in our diet. These 3-in-1 or total nutrient admixture containing IV fat emulsion, dextrose, as we had mentioned, and amino acids is widely used. So it's pre-prepared. So what's interesting about the fact that IV fat emulsions may be added to the mixture, may be given in addition to it, we'll talk about that a little bit later when the book mentions it, but we may also have these pre-mixed parenteral solutions. And if you're on the floor as a new nurse and you're just like, I've never done this before, make sure you ask someone. I'd rather be annoying to someone than wrong. That was my motto, and I was annoying a lot of the time. So let's require this premixed parenteral nutrition solution requires mixing. So require mixing the chambers of dextrose and amino acids, which I'm abbreviating as AA, chambers prior to use. And that would be kind of similar to those of you who have seen antibiotics when they're attached to those bags of saline. Once you pull them out of the Pyxis and you attach them on there, sometimes you'll break a little column inside the bag, and then that will allow exchange of the powder of the antibiotic and the fluid. So you kind of squeeze the fluid down. This is one of those setups to where you can mix it right prior to use. There are some standard electrolytes available in some, but what you really want to know is what is found in this parenteral nutrition, because when we talk about fat emulsions, we're also going to be talking about the fact that egg phospholipids may be used. And we're familiar with the flu shot that we need to know that if our patient's allergic to eggs, if that's used in that vaccine, but also with these IV fat emulsions. So these standard electrolytes are available in some. And multivitamins may be added before use. In terms of the source of calories, this is what I was talking about being really interesting. So our body, when we're in a state of starvation or just regular metabolism, what our body tends to use first is glucose. And then it moves, so glucose are carbohydrates, and then it moves to fats, and then it moves to proteins. So that the body, in a way, and you'll have read this in your A&P books in the past, the body, quote unquote, stores proteins in the form of tissues. Well, it makes sense that we wouldn't want to break down those tissues because they're making up the organs of our body. So that's why it's the last resort. So when we're talking about the source of calories within a parenteral nutrition bag, the patient will receive carbohydrates or sugars in the form of dextrose. And we're going to talk about the nursing implications of this, but I just want to emphasize, if a patient is receiving fluids that have sugar in them, you're probably going to want to do capillary blood glucose checks periodically. Usually in the ICU, it would be around 4 to 6 hours. That's me speaking from experience, but make sure you know what your book says about that. Now, with carbohydrates, dextrose is that sugar, and there's about 100 to 150 grams per day that has a protein sparing effect. So this is what I'm talking about your body prioritizing the use of macromolecules, which are interchangeable with just like nutrients that we use in our body. Those are our carbs, those are our fats, and those are our proteins. Providing non-protein calories in the form of glucose and fat allow the amino acids to be used for wound healing. So because we're giving the patient this specific amount of sugar per day, the body wants to gobble that up instead of gobbling up those amino acids to make tissue, or to use it as energy rather than making it for tissues, because we want the patient to heal. And if you guys have questions about that concept, please feel free to reach out. So keep in mind that this sugar balance is based on, that's what that protein sparing effect means when we talk about that in the book. Because we have sugar available, it's not going to break down the protein for energy. So then the proteins or amino acids can be used to create new tissues and heal. All right, so the next thing that we'll talk about is fat emulsion. And if you think about it, we know that bile is used, you guys should become familiar as you're moving through and have already seen it in A&P, that bile is used to emulsify fats in the digestive tract. Well, it's not like we can just give butter IV, as much as Paula Deen would love to be able to do that. We actually have to emulsify the fat before we put it into the patient's vein, because that fat is not passing through the GI tract, and so that fat has to be emulsified to go into the bloodstream and be able to be carried throughout. Remember, fats are hydrophobic. So when we're talking about fat emulsion, solutions may include 10, 20, and 30% available. %, 20%, and 30% available. So at 10%, the patient is receiving about 1 calorie per ml. So let's say I'm drinking a glass of water. That's about 240 mils. So then that would be about 240 calories that I'm drinking. So think about how many calories are in that fat emulsion, which, remember, the body breaks down sugars, then it breaks down fats, then it breaks down proteins. So this is almost like I like to think of it as like a safety net for after the body's used enough glucose, now there's fat available, so it's not going to break down any more tissue, which is the entire problem in the first place, that their tissues are damaged. Now 20% is, as you can guess, 2 cals per ml. And the book doesn't mention 30%, but I would assume it'd probably be 3 cals per ml, but don't quote me on that because it's not actually in the book. Keep in mind that the fat emulsions that you see also contain different types of oils or triglycerides. So under fat emulsions, we're going to keep going. They also contain soybean or safflower triglycerides with, like I said, egg phospholipids, added as an emulsifier, which makes it easier to metabolize. Oops, a little reversal there. Easier to metabolize. Like I said, there are a large amount of calories per ml. Okay. What do you think that would benefit a patient who has a certain condition? Let's say someone's in heart failure. If we have a fluid that's more dilute and we give that to the heart failure patient versus a patient that's less dilute and more concentrated, that could help them avoid fluid volume overload. So that's beneficial for patients in fluid volume overload, FVO, fluid volume overload. And that's because you have to give less of the liquid than you would if it were more dilute. So make sure you guys understand that fluid and electrolytes concept of what is dilute and what is concentrated. And go back and look at those videos if you need to. With the fat emulsion, it should provide about 20 to 30% of total calories in terms of the fat emulsion. Of parenteral nutrition. The max dose of fat, max daily dose of lipids is 2.5 grams per kilogram per day. I know that kind of looks like 25. Let's see what I can do here. 2.5 grams per kilogram per day. And that's for those patients that are critically ill, would receive that maximum because they require enhanced tissue healing. Many patients may not tolerate that. Think about our critically ill patients may not be able to tolerate that. Go back and look at your sympathetic nervous system and look at your long-term stress hormone, cortisol. Think about what's happening with your metabolism when those hormones are released, when epinephrine and norepinephrine and cortisol are released. Think about those side effects because that's what's happening with these patients who have a sympathetic nervous response. And remember when Miss B and I were talking about spinal cord injury, that patient below the level of injury does not have that sympathetic nervous response. It's going to be more of a parasympathetic nervous response because we don't have those action potentials being transmitted up to the spinal cord to say, oh, I need my heart to beat faster, I need it to, bronchodilate. So think about what's happening in the actual body physiologically. So some nursing implications that are really important when you're giving fat emulsifications. So serum triglycerides, we need a baseline. We need to know what are their serum triglycerides at the beginning before we've given parenteral nutrition. And then after that, closely monitored. Because too much fat, we know from level 2, is not a good thing when it develops into atherosclerosis, especially in conjunction with too much sugar, which is inflammatory. So with your fat emulsifications, they should be administered separately over 12 hours with an infusion rate not to exceed 0.5 mLs per kilogram per hour. So for a patient who maybe weighs 100 kilograms, they should not be receiving, that would be times 100 kilograms. That would be 50 mils per hour. It shouldn't exceed that, right? So you want to make sure that order is correct, because we're the last line of defense before we administer that medication, which we know that if fluids are medications, then TPN is definitely medication. If we have to call for a doctor's order for a diet, then we definitely need a doctor's order for TPN or PPN. Pay attention to this part here. There are some contradictions or contraindications. Patients who have a problem with fat metabolism. So an example of that would be hyperlipidemia. So someone who already has too high triglycerides. And you also want to think about the fact that patients have been through trauma, which means that big bones could break. And I know that in level 2, we probably talked about this, LPN transition, we probably talked about this. But if we have a femur fracture, what's inside that bone? Well, there's yellow bone marrow, which is made up of a lot of fat. So you need to use TPN or PPN cautiously for those at risk for a fat embolism, e.g., for example, femur fracture. And then finally, as I had mentioned before, use cautiously. For those at risk for fat embolism, I started rewriting the last line. My mind was elsewhere. So any allergy, as I had mentioned before, was the part that I was starting on, to eggs or soybeans. I actually did that on purpose just to emphasize that you should use it cautiously for those that may be at risk for fat embolism. Moving on to the protein that's found in total parenteral nutrition or parenteral nutrition. The protein is used to ensure a positive nitrogen balance, which you thought you got away from in level 1, but it's coming back. Positive nitrogen balance. And we want more nitrogen so that we can create more protein, so that we can create more tissues, because nitrogen is essential in constructing protein. The rate of protein administration is 1 to 1.5 grams per kilogram per day. Underneath that bullet point, it's indicated to be used at a higher rate for nutritional depletion or stress of illness or surgery at 2 grams per kilogram per day. For patients who have experienced burn or trauma, greater than 2 grams per kilogram per day. So if you remember from level 3 how much protein those patients lose after a burn, that albumin leaks through the broken capillary membrane. And remember that that's given at a certain period of time during the burn treatment, not right away, because otherwise that albumin would just leak out into the tissues and pull even more fluid in. So remember, according to your acute intracranial problems chapter, that nutrition needs to be started within 3 days of injury. Some restrictions for protein within TPN or parenteral nutrition is 1 gram per kilogram per day, which is less than normal for those with nutritional depletion. And that would be for someone who can't process the byproducts of protein, which may include end-stage renal disease patients who are not on dialysis. And you'll come into contact with this information. Just keep in mind that when we digest proteins, we have a byproduct that is converted by the liver. That byproduct is bilirubin. It's conjugated by the liver, and we also have a byproduct called urea, which is going to be excreted through the kidneys. So if we are administering too much protein to patients who don't have adequate kidney function, then they will not be able to eliminate that urea, and the urea will build up. So let's talk about electrolytes, because those are essential. This depends on the patient's condition. So obviously, if a patient were hypernatremic, we wouldn't want to give them excess sodium in TPN or PN, as it's called in the book. This is dependent on the health problem. Remember, we're looking at our patients holistically. And like I said, it's dependent on the serum electrolyte level. For electrolytes, make sure you see the levels in the textbook. And like I said, use your index and make sure you do your reading, because you won't miss it if you do your reading. Trace elements and vitamins. Are also found in there, and we mentioned some of them earlier. Now, what I want to move to is the method of administration, because you had heard me mention central and peripheral. So central is going to be the first type we'll talk about. So that's central PN. Indications for central parenteral nutrition are going to be, obviously, central is going through a central line, whether it's a PIC or a central venous catheter, and that goes in conjunction with indications for those lines. It's a need for long-term support. It's not like if someone comes hungover into the ER, they're like, we got to put a central cath in right away. Like, no, you just give them a little IV fluid and they can be on their way. We can use a peripheral line, hopefully. High protein and caloric requirements, and this primarily has to do with the viscosity and the ability of the solution to dilute within the blood, or diffuse into the blood, that is, I guess, if you want to be really sciencey about it. Administration. That's usually through a central venous catheter. According to your book, that's supposed to be a C, but it looks like an E. And then also through a peripherally inserted central catheter, and we will be talking about this in the next video, unless you've already watched it. I'm just making this one first for no particular reason. So that would be called a PIC line. You guys are familiar with PIC lines, hopefully. The central venous catheter and PIC lines we're going to be talking about. We're also going to be talking about ports as well in the other video. Solutions that are used for parenteral nutrition, for central parenteral nutrition, are extremely hypertonic, which is why it requires such a large line. So hypertonic, that's 1,600 milliosmoles per liter. That's an M right there. Milliosmoles per liter. Our blood is normally 375 to 395 milliosmoles per liter. So that tells you it's quite concentrated is the word I'm looking for. The glucose is about 20 to 50%. So, when we're talking about a patient whose blood sugar dropped to 40 and we're giving them the IV D50, this is what that solution is as well. All right, so bringing me to the point that I just made, I'm trying to count the boxes so I don't get you guys confused about which bullet points I'm using, because I'm neurotic. So this hypertonic solution must be infused into a large central vein for rapid dilution into the blood, so that it just is diluted by the blood basically and spreads throughout the body. It's bypassing the GI system. So basically the way that I think about it is really like if you took like a sterile, if you took all of the nutrition that you normally eat, pulled out all the nutrients that you needed, made them sterile, that's bypassing the entire GI system so that you no longer have to use it for a brief period of time, because you don't want to bypass that GI tract for very long. Otherwise, we know that the GI tract is not sterile. So if we just let the GI tract sit there, a fecal impaction could occur. There's bacteria in the GI tract, and if the patient's case worsens, and you'll come across this in test 3, bacteria can actually migrate from the blood vessels within the intestines into the blood vessels, like systemically. So we need to make sure that while we are infusing, TPN, total parenteral nutrition, which is called parenteral nutrition in the book, that we are aware that this is temporary. Like, even though it's long-term for these patients, it is going to be a temporary requirement. Like, wouldn't it be super convenient if we could just walk around with, like, an IV bag on our backs with an IV, like a central line, and just like be fed all day. You don't have to worry about eating meals. Sometimes you feel like that in nursing school, I'm sure. Anyway, I went on one of my weird tirades, but let's get back on track. If the vein is too small, so what if I try to infuse this very viscous, meaning very thick, and very hypertonic solution? This central parenteral nutrition would cause irritation and thrombophlebitis at the site. So it's going to irritate that very, very small vein. It's sort of like what we talked about in the other workshop with Miss B, how she said, the book says you need at least a 22 gauge. It's better to have like an 18 or a 20. But with red blood cells, you don't want them to get all clotted up in the catheter, because it's not big enough for the blood cells to fit through, and you don't want to damage those red blood cells as they go through. Well, if we have this really viscous fluid moving through this tiny little catheter, it's kind of like forcing Jello through a straw. That's the best example I can come up with off the top of my head. But that's why we would be using a larger catheter for that central parenteral nutrition. So in terms of peripheral parenteral nutrition, or PPN, it's usually given through a peripherally inserted catheter, which just means a plain IV. So given through an IV or vascular access device into a large vein. So we're not giving it into one of the smaller veins that you find in the hand, which most people don't really go through anyway because they're a little hard to stick. And given the fact that parenteral nutrition is a little bit more viscous than IV fluids, we wouldn't want to use a smaller catheter anyway, because that makes it harder for it to go through that catheter. Indications include nutritional support, obviously. Needed only for a short time. So as opposed to central parenteral nutrition, this is for a short time. And that goes the same for central lines and PICC lines. This would be for a patient whose protein and caloric requirements are not high. Not high enough, that is, to warrant central parenteral nutrition. Perhaps for a patient, the risk for central catheter is too great, and we'll go over that in the CVAD section, understanding what the risks are when it comes to inserting a large catheter in through either the basilic vein into the superior vena cava just above the right atrium. You can imagine like inserting something foreign into almost the heart can be quite invasive and comes with risks. And then it is also indicated to supplement oral intake, an adequate oral intake. let's look at the differences between central and peripheral parenteral nutrition. And I'm just going to abbreviate it as central parenteral nutrition and peripheral parenteral nutrition. In peripheral parenteral nutrition, there are fewer nutrients. It is therefore less hypertonic, about half of what the central is, which is 800 milliosmoles per liter for the peripheral parenteral nutrition. There is some risk for phlebitis, but not as great as central parenteral nutrition. And unfortunately, this may cause fluid volume overload, as it requires large volumes of fluid. Now I want you to pay attention to the table in either of your books. Some of you have the 10th and 11th edition, so again, refer to your index and refer to your table of contents to find where that is. That would be table 39.15, and I'm not sure exactly what number that is for the 10th edition, but it should come within that section on parenteral nutrition. It's a giant red table that says nursing management, and then underneath it in black and white it says PN infusions. So make sure you look through that. So let's talk about the nursing management of PN in general. And this is also a heading in your book that you should be reading. I know you guys love hearing me say that. So some complications associated with this type of nutrition include the biggest one, which is refeeding syndrome. Anytime you hear the term gold standard or hallmark, which I think I've used at least once during this workshop, make sure you pay attention. So having said that, be on alert for when I do use that term. This may occur, refeeding syndrome may occur with too aggressive nutritional support. Let me see real quick. That's 4 boxes. Okay, 4 boxes in. Alright, and characteristics of refeeding syndrome include its hallmark, which I'll be mentioning soon. The first of which would be fluid retention. So all those signs that your patient's in fluid volume overload. Electrolyte imbalances. And here we go. The hallmark of these electrolyte imbalances are going to be hypo, meaning low, phosphatemia. And if you need a refresher on what that looks like, make sure you go back and study that part of the Fluid and Electrolytes chapter. There are also videos you can find on the NIP Student Commons. The patient may also experience hypokalemia, which is not spelled like that, or that. So low potassium, and hypomagnesemia. So a loss of these electrolytes. Some complications. Actually, going to move one over. Would be honestly associated with those electrolyte imbalances, so that would be dysrhythmias, because we know if we're hypokalemic, we're at risk for cardiac dysrhythmias. Especially with magnesium, we would be at risk for respiratory distress. And then also neurologic problems, because remember, as Miss B said in the previous workshop, magnesium modulates the myoneural junction, which is where that nerve meets the muscle. Some risk factors that are associated with refeeding syndrome in particular include long-standing malnutrition states. So that would possibly include anorexia nervosa. That could include chronic alcohol, or ETOH. You'll see that in the chart as ETOH. Chronic alcohol use, prolonged vomiting, and diarrhea. Chemotherapy. And major surgery, especially involving the bowel. In terms of home nutritional support, if someone is sent home with PN or TPN as it's called on our handouts, and you can find those handouts in the NIPS Student Commons, that may continue for months or years. It's important to teach the caregiver or the patient proper catheter and tube care. And it's really important to consider this because it is directly going into the patient's bloodstream, so we want to avoid infection. Also, proper handling. Of the solutions and the tubing, and proper technique. Some side effects and complications, such as refeeding syndrome, need to be taught to the patient or caregiver. And that would be something like refeeding syndrome, but could also include other things like infection. And that can be found on table 39-16 in your 11th edition. But like I said, if you can't find it, it's going to be in that general section in the 10th edition. So make sure you use your index and your table of contents. Some detrimental effects of TPN is financial ones. It's expensive, and certain criteria must be met for reimbursement. And you have learned a little bit about that in terms of home health, like what requirements you have to meet to meet the qualifications to receive home health from a registered nurse. So make sure you know what those are from your textbook. One thing the book mentions is early discharge planning. Remember, we begin planning for discharge the second this patient is admitted to the hospital, so that applies here as well. And then in terms of the patient's emotional state, potential support groups. With parenteral nutrition infusions, there is a very large table in your book that makes some key points about nursing management. So parenteral nutrition infusion, I just pulled some key points out of that table, and it's a very large, big red table. It is prepared using aseptic technique. I'm not listing all of them here because there are quite a few of them, but make sure you go through those and know what you need to know as a nurse. Daily orders are prescribed for TPN to adjust to the patient's condition. PT is patient's condition. And keep in mind that TPN or PN is good for 24 hours after it's been hung. It should not be taken out of the refrigerator for longer than 30 minutes before it's hung. So refrigerate up to 30 minutes before use. Specific filters and pumps are required. You want to label always, no matter what it is. You really want to label any bag and tubing, especially when you have a patient who has a lot of tubes, with the date and time, but also your initials that it was started. Use a dedicated line, one line for parenteral nutrition, because compatibility is an issue, and you'll learn that as you progress through level 4 that not all drugs are compatible with fluids. Parenteral nutrition needs its own dedicated line, and you need to label that. And you need to label that with the date and time because, like I said, it's only good for 24 hours. This is interesting. You do not draw blood from a parenteral nutrition line. It will give you false results because remember the osmolality of central PN is around 1600 and peripheral parenteral nutrition, that's around 800, which is way above normal in terms of serum osmolality, which is 375 to 395. So you don't want to draw from the line for lab evaluation. It's going to show like extremely high levels of electrolytes and glucose and triglycerides as well. Let's see. I already said use a pump. You want to make sure that it's unoccluded. So most pumps, like the Alaris pump, will give you an alarm that will tell you if the line is occluded. Okay, so you want to listen for that alarm. I know we experience alarm fatigue as nurses, so it's like everything's beeping all the time, but you really want to pay attention to that. You want to check the to be administered. Remember those math problems from level 1? Periodically to ensure that there's no obstruction or incorrect rate set, because that could cause complications. Remember, if we said if we infuse it too quickly, that could cause fluid volume overload and the glucose levels could spike too high. TPN, according to your textbook, should be verified with a second RN. You want to look at the label and make sure that it corresponds to the doctor's order. This is a medication technically. This is huge. You want to replace the bag and the tubing, because the tubing also contains the parenteral nutrition, which could cause microorganisms to grow. So normally, in the hospital, the tubing can be good for so long, like 72 hours, I think it was at Baycare, so you could just switch the bags over whenever you felt like it. But when you needed to change the tubing, that may have been later. We need to replace the bag and the tubing every 24 hours for TPN, or parenteral nutrition. And then you also want to replace the bag and tubing and take a sample if anything looks abnormal, like if there's any sign of phlebitis at the site, if there's any lumps in the fluid where the fat emulsification has sort of like agglutinated, that's not normal. That could cause a fat embolism, that could cause problems within the patient's vascular system. Like I said earlier, we take capillary blood glucose levels every 4 to 6 hours with a sliding scale that's SS insulin to keep blood sugar between 140 and 180 milligrams per deciliter, because these patients are in a healing mode, so they need a little more sugar than normal. If it empties before the next bag is available. It's going to differ based on whether it's CPN or PPN. For CPN, you're going to use a 10 or 20% dextrose fluid to replace it until you can get that bag. If it's a peripheral parenteral nutrition, we're going to use a 5% dextrose solution to hold them over until we can get the new TPN on there. Now, once 60% of caloric needs are met, they should be met before discontinuing the parenteral nutrition, no matter whether it's central or peripheral. So with our patients, we're going to begin very similarly to post-op orders. You begin with clear liquids with a doctor's order, because remember we need a doctor's order for a diet, with clear liquids, and advance as tolerated. All of the basic nursing assessments need to be completed, especially daily weights, because remember that's the best indicator of fluid volume status, but also we're talking about nutrition. And then another huge component is liver enzymes need to be measured 3 times per week. And if they're normal, then weekly. That's exactly what your book says. So that's about it for TPN. I hope you enjoyed this workshop. I know it's a very dry subject, but let me know if you have any questions. If you need any assistance, my email is bailey.megan@spcollege.edu. So feel free to email me with any questions or concerns, and thank you so much for listening. Have a nice day.